Welcome everybody to this parallel symposium on pediatric inflammatory bowel disease. On behalf of myself and my co-chair, Dr. Beatty, I welcome you, and we will get started with some very interesting talks, I'm sure. The first talk is by Dr. Olin. Dr. Olin is an associate professor at the Karolinska Institute in Sweden, and will speak to us about a topic close to my heart, the epidemiology of pediatric inflammatory bowel disease.
Hello everyone, my name is Ola Olén. I'm a pediatric gastroenterologist and a clinical epidemiologist from the Karolinska Institutet in Stockholm, Sweden. And for the next 18 minutes I will be presenting a global view of PIBD epidemiology. The agenda for my talk can be summarized as follows. Why is clinical epidemiology important for PIBD? Questions clinical epidemiologists usually focus on and how data sources can be used to achieve the goals, incidence and prevalence of PIBD, and examples of other types of clinical epidemiology reports regarding PIBD. In explaining what clinical epidemiology is, I would like to start with describing what clinical epidemiologists should not be doing. We should not be presenting thoughtless and more or less panic-inducing relative risks of seemingly random nature and questionable clinical value. That has definitely been done in the past and given rise to comic strips like this one. Clinical epidemiologists should instead focus on what we really want to know about disease. Who is susceptible for PIBD? What triggers PIBD? How is it diagnosed and what is the prognosis? How do different patients respond to different treatments? Are the treatments safe? What comorbidity can be expected? And does it affect treatment response and prognosis? What does it all cost? We all know that in the hierarchy of study designs, meta-analysis of multiple well-designed and large RCTs represent the highest level of evidence, followed by RCTs and observational non-interventional cohort studies. In reality, RCTs in PIBD are only able to answer questions of treatment response, whereas all other research questions we're interested in are impossible to answer with an RCT for practical or ethical reasons. It's therefore not surprising that most guidelines are based on RCTs to a very little degree. The systematic breakdown of evidence supporting the European Society of Cardiology guidelines, for example, showed that only some 13% of recommendations were based on RCTs, while more than half of recommendations were based on consensus expert opinion. We of course need to perform more RCTs, but we also need to better take advantage of the possibilities of high-quality observational research. As a clinical epidemiologist, I therefore focus my observational research on questions that patients, families, or clinicians really want to know the answer to, questions that might even have the potential to change clinical practice, and questions that are impossible or very unlikely to ever be answered by a clinical trial because of costs or ethics, and where observational studies therefore represent the best level of evidence. So, how is clinical epidemiologic research of high quality performed? First, we need to acknowledge that all data sources are not created equal. Different data sources are optimal for different research questions. Administrative registers are often population-based, have a higher complete coverage on many important variables such as healthcare contacts, but have no coverage of some other often very important variables such as smoking or certain types of healthcare contacts, and above all, disease activity measures. The coverage, selection, and how codes are used is influenced by healthcare system and the reimbursement model. Prospective or clinical or quality register cohorts are often not population-based, have low or no information about healthcare contacts outside the subspecialty, but have, on the other hand, excellent information about disease activity and lab and drug exposure. The coverage and selection is often dependent on enthusiastic and engaged colleagues at multiple sites, which means that you often have an increasing coverage and incidence over time. Administrative registers typically need to be used if you want to have nationwide estimates of incidence and prevalence. You will use administrative registers for assessments of healthcare costs and healthcare use, and you will use those registers when you need IBD to assess mortality, cancer, infections, and such outcomes that are often captured very well in such data sources. Clinical cohorts, on the other hand, will have to be used if you need information about phenotypes and disease activity and quality of life and such. In countries where personal identifiers are available, it is possible to link data sources. For instance, national registers with complete coverage and good information about healthcare consumption, comorbidity, and dispensed prescriptions can be enriched by more granular information about phenotypes and disease activity from a clinical quality register, or even information from biobanks. Needless to say, the possibility of linking registers generates a sea of data, and given a large number of risks for bias, it is very easy to get lost in the waves. Therefore, a word of caution for anyone who aims to embark on a project involving a lot of data. Please make sure to build a team consisting of co-workers with both clinical know-how, epidemiological know-how, data management and data analysis know-how, but also pathophysiological know-how, so that the right questions can be asked and so that seemingly spurious findings can be better explained. The main types of clinical epidemiology research questions from IBD teams across the globe can be summarized as follows. First, we have the landscape studies, studies reporting incidence, prevalence, validation of different variables and their definitions, reports of healthcare use and such. Then we have etiology reports, looking into risk factors for IBD, safety studies of how safe different treatments are in the long term, effectiveness reports comparing different drugs, cost analysis, and prognostic studies. Let's dive into the first type of research question. What is the incidence and prevalence of PIBD today? Already in 2016, IBD was considered a global disease with vastly varying incidence and prevalence, with an accelerating incidence in newly industrialized countries and with a stabilizing incidence in Western countries, and with a prevalence that surpassed 0.3% in many countries. As you can see on the map, incidence is highest in countries with high income, a Western lifestyle, but these countries also have good access to healthcare and registers in place that make it possible to measure the incidence of IBD. The age distribution in different countries, of course, differ a lot. That is important to keep in mind when the proportion of PIBD in the whole IBD population differ vastly across reports. And since children grow older, it's also natural that although some 10% of IBD patients are diagnosed in childhood, only 1 to 2% of prevalent IBD patients are children at any given point in time, as shown here elegantly by our Scottish colleagues. The Swedish experience in this respect is almost identical to the Scottish one. And in Israel, a similar pattern has recently been reported. Incidence of IBD is well known to be highest from adolescence to young adulthood, albeit less pronounced so in UC than CD. Here you can see recent Canadian data from the different provinces. And here you have the corresponding Danish data. Since the incidence is increasing so rapidly between 15 and 18 years of age, the cutoff chosen in different studies will of course affect the reported incidence rate immensely. And in different studies you usually have below 15 as the definition, or below 17 as in the Paris classification, or below 18 as in the WHO classification. A recent systematic review and meta-analysis of incidence and prevalence of PIBD in Europe reported that the incidence of pediatric IBD continues to increase throughout Europe. Here you can see graphs restricted to national databases. Please note that the different studies have used different age cutoffs, which is reflected in the different incidence rates, but the increasing trend is constant. One large cohort of European PIBD cases was not included in the aforementioned meta-analysis, likely because of the title of that paper. In that study that compared incidence and healthcare use in different age groups of IBD onset with each other and with matched controls from the general population, you can also see the incidence rate over time. Apart from an administrative incidence peak in 2001, when outpatient data was added in Sweden, you can here see that the incidence of Swedish PIBD is rather stable during the last 5 years of the study period. In a very recent Israeli study, you can even see a trend of decreasing incidence in both adults and especially so for UC, but also in childhood onset UC. Please note that in the Israeli study, incidence data was only reported up until 2017, although prevalence data was available until 2018. One of the reasons for that is well visualized by this Danish study, in which you can see a sharp decrease in IBD incidence for all age groups during the last 4 years of the study period. This has several reasons. In this slide, you can see how definitions of IBD requiring different number of diagnostic listings in the Danish patient register will result in different shapes of the incidence curve during the last years of the study period. This is because increasing number of diagnostic listings required will result in ever longer duration between first and last listing for the definition, which in turn will mean that fewer and fewer individuals will even have had the chance to fulfill the IBD definition requirements in the end of the study period. Thus, a very complex definition of IBD that extends over a long period of time for a large proportion of the study population can mean that a true increasing incidence might be misinterpreted as a stable or even decreasing incidence. This is very important to keep in mind when we try to interpret and report incidence rates over time. Yu and colleagues in their Lancet paper from 2017 concluded that the prevalence of IBD of all ages is above 0.3% in many countries. But since mortality in IBD is not that great and the incidence peak is among younger individuals, the predicted prevalence of IBD is steadily increasing. 2 recent reports from Canada and Scotland predicted an IBD prevalence close to 1% in 2030. Since IBD patients are frequently tested, undergo endoscopic surveillance, and receive multiple treatments administered in hospital, that prediction will have to lead to innovative ways of using the limited gastroenterology resources we have. Apart from incidence and prevalence reports, I will also give you some examples of other types of research questions that clinical epidemiologists should focus on with regards to IBD. In a recent report, our Canadian colleagues elegantly reported that hospitalizations and surgeries have decreased in recent years, while outpatient visits have increased since anti-TNF treatments have become available. In a Scottish study of some 2,000 CD patients of all ages, they found that during a period when anti-TNF use increased massively, the 10-year cumulative incidence of abdominal surgery decreased from 30 to 20%. An almost simultaneous study from Sweden also found the 10-year cumulative incidence of first abdominal surgery in Crohn's disease to be close to 20% in the most recent time period, and also observed a sharp increase in the use of anti-TNF during the same time period. In Scotland, rates of biologics prescriptions have increased sharply since 2015, and since then the continuous decrease of colectomies have started to decrease even more abruptly. Among IBD patients in Manitoba, Canada, the mean annual steroid doses have continued to decrease the last 15 years, a process mostly driven by less steroid use in the anti-TNF treated patients, and this was true for both Crohn's disease and ulcerative colitis. Registers are excellent data sources for etiologic research, and here are a few examples. Recent Canadian studies have found green space and less air pollution to be protective of PIBD development, whereas Swedish and multinational studies have found antibiotic use to be associated with an increased risk of IBD, and adherence to a Mediterranean diet, which shares several properties with the Crohn's disease exclusion diet, is associated with a lower risk of CD. As examples of observational PIBD safety studies, I want to highlight the following. In propensity score matched analysis, a Swedish-Danish group have estimated the risk of serious infections in children exposed to anti-TNF compared to equally sick children with PIBD and found no increased risk. In another study, the same group have estimated the absolute and relative risks of acute pancreatitis after azathioprine exposure, and an American-French group of researchers have looked into the risk of serious infections comparing vedolizumab and tumor necrosis factor alpha in adults and found a somewhat protective effect in the video-exposed group. And then some examples of effectiveness studies. Our Canadian colleagues have shown that a combined biologic and immunomodulatory therapy is superior to monotherapy for decreasing the risk of inflammatory bowel disease-related complications for both Crohn's disease and ulcerative colitis. But everything has a price, and resources are not limitless, which is why studies of economic outcomes are important. A recent systematic review concluded that in pediatric IBD, costs in Crohn's disease were higher than in ulcerative colitis, and that overall direct costs shifted from inpatient hospitalization to anti-tumor necrosis factor agents as the leading cause of direct costs, and predictors of high costs, of course, included uncontrolled disease and comorbidity burden. An even more recent report showed how direct costs for PIBD have increased since the advent of biologics. Last but not least, I want to mention prognostic studies. Many of the outcomes we're interested in are rare and/or will happen in a distant future, such as death or cancer. This is where clinical registers often come up short, and where mandatory nationwide registers with complete follow-up are necessary. For instance, the research question regarding pediatric IBD and cancer has proven to be a hot topic the last year, with 3 reports on PIBD and cancer risk in general, and a whopping 6 studies reporting on different types of cancer, and with PIBD risks reported separately. In summary, the risk of several types of cancer, especially GI cancer, lymphoma, and skin cancer, are increased, although absolute risk increases were very small for most cancers. Okay, there you have it. We have covered the main types of clinical epidemiology research questions in IBD today, and with that, I will be happy to try to answer any of your questions. Thank you, and see you all in beautiful Edinburgh next year.
Thank you very much, Olin. That was a beautiful talk, and I think shows a lot of unanswered questions, but also the work that's been done over the past 10 years in pediatric IBD epidemiology, which is phenomenal. So I remind people to put questions into the Q&A session. I can start into the Q&A box. I can start with a question if you don't mind. You showed the changing epidemiology of pediatric IBD, or of IBD in general, between 15 and 18 years old, and particularly a shift from the 2/3 male population that we see, particularly in Crohn's and pediatrics, to a more even split, as well as a very rapid rise around the time of puberty. And I'm wondering if you can explain that change or any way that we can study that as to why it's happening around that age.
Oh, that's super interesting. And as you know, of course, but maybe everybody else does know, we have recently published a study where we looked into that in the whole of Western countries, and also and I think you also published in the corresponding report for Eastern countries, where we looked into that sex difference over different years or different ages. And my interpretation is simply that it's obviously got to do something with puberty and the estrogen pressure. I don't know how to say this in English, but definitely estrogens play a role, and maybe it has got to do something with the permeability of the gut and what have you. I don't know if I understood your question correctly, but
yeah, no, that's exactly it. I mean, my question is why? Why is there this change around the time of puberty? And there's lots of hypotheses, including hormonal changes, but I don't know of any answers yet, and I'm wondering if if people who are studying that or not.
Oh. No, I don't. I'm sorry.
Good. So another unanswered question about the epidemiology. Yeah. Absolutely. Yeah. So Dr. Beatty has a question, and he's co-chair, so he could come on and ask it verbally if he wants to, but I can say on his behalf then, if the incidence stabilizes, then can we predict the prevalence will stabilize, particularly with younger age at presentation?
Well, if incidence stabilizes as it is now, and since the incidence is so high in the younger ages, and mortality, it's not a very mortal disease, then prevalence will keep increasing for quite a few years. It's beyond me to say when it stabilizes, but of course it will stabilize at some point.
No, absolutely, that's great. Thank you. Okay, so with that, we will thank you, Dr. Olin, and perhaps move on to the second presentation of this session. Dr. Christopher Burgess will be presenting an oral abstract. Dr. Burgess is from University of Edinburgh in the United Kingdom, and his abstract is entitled Childhood and Early Adult Life Sequelae of Pediatric Onset Inflammatory Bowel Disease, a Scottish population-based nested case control study of ischemic heart disease, stroke, cancer, and mortality risk.
Thank you for the opportunity to present this work on early adult life morbidity and mortality for pediatric onset IBD patients. Although I'm now living and working in Brisbane, Australia, I'm presenting this work on behalf of the Scottish PIBD Network. It's no secret that pediatric onset inflammatory bowel disease, as with any chronic immune-mediated inflammatory disease, increases our patients' risks of morbidity and mortality. This increased risk can be related to both chronic active inflammation as well as to the treatments used to induce and maintain disease remission. Morbidity and mortality risk is, of course, one of the major concerns to our patients and their families, especially at diagnosis and at transition to adult services, when patients naturally try to envisage what their future lives will look like and what challenges they will face. Early adulthood, age 17 to 39, is the key area of concern, as this is a time where people naturally expect themselves to be living a healthy and fulfilling life. As paediatricians, we rarely have to think about events such as ischemic heart disease and stroke, despite these having been shown to be an increased risk for adult IBD patients. We're acutely aware of the increased cancer risk to our patients, but we usually think of this in relation to immunosuppressive therapy and not due to chronic inflammation or undertreatment of IBD. And we rarely have to confront mortality associated with IBD and its complications. We therefore aim to determine whether PIBD patients are at increased risk of ischemic heart disease, stroke, cancer, or death during early adulthood in a nationwide population-based study using administrative health data. Scotland is an ideal place to investigate PIBD outcomes due to its robust national administrative health data, easy data linkage, its established PIBD network, and the National Public Health Service. To perform our study, all children coded for PIBD within Scotland between 1981 and 2017 were identified within the Scottish Morbidity Record inpatient dataset. PIBD cases were defined as any primary inpatient ICD coding for Crohn's disease or ulcerative colitis until age 16. Validation of ICD coding was performed within an entire Scottish Health Board by individual case note verification, and previously validated nationwide registries were also utilised to assess the accuracy of our data. A nested case control study 1:3 ratio with controls matched for sex, age, postcode sector and deprivation quintile within the Scottish population was performed. Data linkage was applied to SMRO1 for ischemic heart disease and stroke diagnosis, SMRO6 the Scottish Cancer Registry and the National Records of Scotland Deaths dataset. Hazard ratios were calculated for each outcome using mixed effects Cox regression, and the potential effects of sex, year of diagnosis and age of diagnosis were explored. Analysis of early adult life outcomes was restricted to PIBD patient outcomes between the ages of 17 and 39. The overall study population comprised 1,907 people with PIBD and 5,720 matched controls. Total follow-up time until age 39 was 127,000 person years. Median duration of follow-up per person was 16 years. The median age of PIBD diagnosis was 13, and the median age at the end of follow-up was 27. Overall, the risk for ischemic heart disease and stroke for PIBD patients in early adult life was interesting but underwhelming due to low numbers. PIBD patients did not appear to have an increased risk of ischemic heart disease, with less than or equal to 5 cases and less than or equal to 5 controls identified, providing a p-value of 0.795. PIBD patients did, however, have a significantly increased risk of stroke in early adult life. However, again, only low numbers were identified, highlighting how rare these thromboembolic outcomes are in early adult life and that international collaborations would be required to demonstrate true significance. The overall cancer risk in early adult life for people with PIBD is twice that of the general population, with 54 cases identified and 80 controls. This cancer risk can be further analysed to focus on those cancers we commonly see related to inflammation of the gastrointestinal tract and possible undertreatment of active disease, including small bowel, colonic, rectal, anal and hepatobiliary cancers. The risk of these disease-related cancers in our PIBD cohort was an impressive 50 times greater than controls, with 17 cases and less than or equal to 5 controls identified. For those cancers we commonly see related to immunosuppressive therapies used to treat IBD, including lymphoma, leukemia, myeloma, and PTLD, the risk was 5 times greater in PIBD patients than controls. The overall mortality risk in early adult life for people with PIBD is 3.3 times that of the general population, with 46 cases identified and 42 controls. Further breakdown reveals significantly increased mortality risk for PIBD patients from infection with a hazard ratio of 12.1 and from cancer with a hazard ratio of 16.7. The mortality risk from suicide was 2.3 times higher in PIBD patients, although this was not statistically significant. Validation of cancer risk utilising cases previously identified as true positive in prospective nationwide Scottish PIBD registries revealed no change in the hazard ratio, confirming the accuracy of our administrative health data. Subgroup analysis also revealed no major difference between hazard ratios for patients with Crohn's disease and ulcerative colitis. Sensitivity analysis demonstrated a higher effect of PIBD on cancer risk in males, but no significant effect on patients born before the year 2000 or in patients diagnosed less than 10 years of age. Similar validation of mortality risk also confirmed the accuracy of our administrative health data. This time, a higher risk of mortality for Crohn's disease patients was noted, with a hazard ratio of 4.2 versus 2.75 for ulcerative colitis. Sensitivity analysis revealed no significant effect of PIBD on mortality risk in males, in patients born before the year 2000, or in patients diagnosed less than 10 years of age. Within this robust nationwide nested case control study, we have been able to demonstrate that ischemic heart disease and stroke are rare events in early adult life, and any significant risk related to PIBD will require larger collaborative studies. Cancer risk in early adult life is 2 times higher for patients with PIBD, with possible disease-related cancers 51 times higher and possible treatment-related cancers 6 times higher. Mortality risk in early adult life is 3.3 times higher for patients with PIBD than the general population, with a disproportionate increase in the risk of death from infection and cancer. These are useful real-world statistics when considering the potential severe impact of IBD on our patients in early adult life, when discussing treatment options with families, and when highlighting the importance of early effective control of inflammation. Thank you.
Thank you very much, Dr. Burgess. That was fantastic. Excellent. Very interesting study. We have a couple of questions. Professor Turner asks, what was the cancer risk by age 18, so pediatric onset cancer, and what was the cancer risk in those untreated with either biologics or immunomodulators?
So that's a very good question. We deliberately didn't include cancer risk in those patients less than 18 years of age because we were specifically looking at early adult data. So we do have that data available, but I don't have those numbers with me. But the numbers were very low in children less than 18. And the second question there, Eric?
Apologies. What about those untreated with biologics or immunomodulators?
Yes, with the Scottish Administrative Health data, we weren't able to link in medications because that data set only came in much later than the data we'd obtained. So we do not know which of those patients were on biologic and thiopurines. And of course, that information would be useful in the future.
Great. And I do want to ask a question myself, and then I know Mark has a question as well. Regarding the stroke risk, you related that to venous thromboembolic disease, which it may well be. And we heard earlier the higher risk in the PIBD safety registry, the SETI study, earlier this morning. So my question would be, did you separate out the stroke risk in people around the time of hospitalization to see if this might have been related to active disease, or is this an overall elevated risk of stroke?
So the numbers were so low, Eric, that we decided not to delve into it too much. And simply, these are patients who have presented for an inpatient admission with a primary code related to an acute stroke event. So whether that's related to their IBD and around a time of a disease flare, we don't have that information at present. But those numbers are so low, it would be difficult to pull out any more true advantageous sort of comparisons from that.
Thank you. And Mark, I'll let you ask your question. And we'll just remind everybody that if we don't get to your question, the presenters can respond to your questions in the Q&A box. So keep an eye out.
Yeah, thank you very much for your great talk and great insights. Can I ask you how much you think that treatment might impact on mortality? Because that's quite a complicated discussion when you have it with families. You can say inflammatory bowel disease is a cancer risk, for example. Treatment might reduce the cancer risk as well as increase it, if you see what I mean. I wondered if you'd got any insights from your work on that.
My feeling is that this work, Mark, shows that those patients who choose not to go down routes where they might be offered medications which can increase cancer risk, but which we feel will decrease their disease burden and their active disease flares, I think it helps some families make those decisions when you can clearly say, your risk of getting cancer from active disease is 50 times greater than the average population, whereas if we have you on thiopurines or potentially immunosuppressive medications, that risk is still higher, but only 5 times greater. And I think it's also useful to see that mortality risk with PIBD patients is there in early adult life. And so we assume that is due to active disease rather than just treatments. But of course, we don't know that. But I suppose any significant mortality risk early on in life is a big worry for families. So I think that does push families to accepting treatments more readily.
Thanks very much. So I'll introduce myself now as the co-chair. I'm Mark Beattie, a paediatric gastroenterologist from Southampton, and it's a great pleasure to be on this session. I would like to now welcome Professor Holm Ulrich, who is well known to you all as Professor of Pediatric Gastroenterology from Oxford, and he's going to answer a question we all find quite hard, which is the practicalities of diagnosis and treatment of very early onset inflammatory bowel disease. So Professor Ulrich, welcome.
It's a great pleasure to present at this 6th World Congress of Pediatric Gastroenterology, Hepatology and Nutrition on the practical approach to diagnosis and treatment of very early onset inflammatory bowel disease. We have reached this age of genomic medicine, and despite of having this scientific approach, it's still important that we remember one of William Osler's quotes to say that medicine is a science of uncertainty and an art of probability, and this is in particular true for an area like monogenic disorders and monogenic inflammatory bowel disease, where our knowledge base is restricted. We can differentiate the polygenic forms of inflammatory bowel disease, in particular Crohn's disease and ulcerative colitis, that present with a peak onset between the 20s and the 40s years of age, from the monogenic forms of inflammatory bowel disease, 75 plus orphan disorders that have a particular strong genetic impact and present typically in the first 2 or 6 years of age, area that we define as very early onset inflammatory bowel disease. What is common to those disorders is that there is a failure rate of anti-TNF therapies, immunomodulatory therapies in very early onset inflammatory bowel disease, compared to the more older and classical pediatric IBDs. And in particular, this is true for monogenic forms. This recognition that there are exceptional, extreme forms that are caused by gene defects in a single gene has led to a revolution in medicine, from identification of those extreme patients to the discovery of single gene defects, the use of exome sequencing, and then a transition towards clinical applications via targeted panel investigations, exome and genome screens, now to clinical applications as a standard of care. What has been observed is that there are distinct histopathological features in patients with very early onset inflammatory bowel disease. Here a study of Judith Kelson and others, where increased rate of apoptosis, villus planting, or eosinophilia was observed. However, all of these findings are unspecific, and it's just a statistical association. Similarly, all the other typical criteria that we apply for the classification of IBD, be it phenotypic, radiological, or histological, are largely unspecific and will not help us in the differentiation between monogenic and polygenic forms of inflammatory bowel disease. And this has led to a concept where genetics is one of the key drivers in making the diagnosis, where we select patients with a high probability of harboring a monogenic variant, where this led to the use of genomics in the clinical field, identification of gene variants, and then with a mechanistic disease model, the application of disease and pathway-specific treatments, such as hematopoietic stem cell transplantation, specific biologics, or novel therapies, including gene therapy. What is important is that these research developments now enter the clinical practice, and as part of the Porto group of ESPGHAN and joined by some research consortia such as the Very Early Onset IBD Consortium, the Genius Group, or the Colors and IBD group, we evaluated recently the evidence to support clinical genomics, the patient selection, screening panels, preferred technologies, functional validation, and the role of a multidisciplinary team meeting, as well as the evidence for cost effectiveness. And that led us to a pathway towards the clinical use of genomics, where we start with an IBD assessment. We assess red flag signs, and then depending on the age of onset in a really probabilistic setting and the presence of additional factors such as red flag signs in the family history or in the clinical presentation or in laboratory findings, we then apply a multidisciplinary team approach, the use of genomics, be it panel, exome, or genome sequencing, the validation of those findings, and then start a team assessment to validate those variants and to plan the diagnostic and therapeutic care plan. As mentioned, there are red flag signs that are key to this approach. And one of the most important findings is if there is a patient with less than 2 years of IBD onset, if there are patients under 6 years of age, this is still very relevant, in particular if there is a family history, for instance, of other family members that are affected, consanguinity, or there is a relevant comorbidity or extraintestinal manifestation, such as infections, hemophagocytic lymphohistiocytosis, malignancies, or unusual findings such as multiple intestinal atresia. About 2/3 of those monogenic disorders have an age of onset under the age of 6 years as a median. However, we should remember that there is still a relevant number of disorders that have age and onset beyond this age, and we shouldn't exclude those patients from the diagnostic pipeline. What we do focus is on key features. And this is an exemplar. It's one of the classical defects, IL-10RB and IL-10 signaling defects where macrophages are not controlled because of the defective IL-10 receptor. And in this family, it's a consanguineous family. Multiple family members are affected. There is an extreme early onset under 1 year of age for family members, and one of these family members developed a B-cell lymphoma. Similarly, there are a number of gene defects that are not linked to classical immune-mediated disorders or immunodeficiency, and as an exemplar here is a metabolic disorder that you would not necessarily associate it with inflammatory bowel disease, a Niemann-Pick type C, a neurometabolic neurodegenerative disorder, where about 7 to 10% of patients develop intestinal inflammation. Again, red flag signs, 2 years of age onset, severe form of inflammatory bowel disease, developed then a splenomegaly. As a metabolic workup, and this patient here presented did then identify plasma oxysterol levels that are abnormal, and then a subsequent diagnosis of Niemann-Pick type C. We have discussed in this position paper of ESPGHAN that there are a number of tests that are required. First of all, an classical IBD workup that includes endoscopy and relevant imaging, some essential blood work that includes, for instance, a full blood count, basic immune workup, for instance, inactivity markers like CRP, immunoglobulin classes, lymphocyte subsets, and then DHR assay to exclude chronic granulomatous disease. Other blood tests are often not required, and only if there are specific phenotypes. There is a basic infection screen that should be performed, for instance, to exclude HIV or tuberculosis as an infectious cause of intestinal inflammation, and stool tests similar to exclude bacterial or parasitic or viral infections, as well as a calprotectin to assess the disease activity. What becomes very clear when following the literature is to value the multidisciplinary team approach, and care of patients with suspected monogenic IBD should be taken in an MDT setting. Here's an exemplar from a patient from Oxford, where the age of onset was in the first years of life. Patient took a very severe course, developed immune symptoms like a severe lymphopenia or a congenital neutropenia. We did perform as part of the MDT and genome sequencing as part of the research, identified a variant in glucose 6-phosphatase, and then transitioned towards the clinical genetics. We collaborated with immunology and the hematology team, and this patient underwent an hematopoietic stem cell transplantation, after which the symptoms completely resolved. The diagnostic yield is highest when genetic investigations are performed in patients with an age of onset under 1 or 2 years of age. And similarly, if there is an family history, if there is a population structure, for instance, patients with consanguinity are enriched, and there is a clear center bias. So there is a clear difference whether you see a patient in a primary setting, or if there is a center bias and this patient comes from an immunodeficiency clinics. The diagnostic yield is depending on technology used. And as one of the exemplars is a study recently published by Alexio Muis group, where over 1,000 patients in a tertiary referral center have been investigated, and a rate of 3% rare variants have been identified, and in 1% there are disorders with a potential of hematopoietic stem cell transplantation. Now, these numbers sound very high. Not every center will have the same frequency. But what is clear is that we need to use these genetic approaches, since otherwise we might miss those patients. This is a study we performed as part of the Colors in IBD consortium, where we selected nearly 150 patients with very early onset IBD, where no Mendelian IBD was clinically suspected. We performed exome sequencing and identified in 4 patients in this group clinically relevant variants that led to hematopoietic stem cell transplantation and assessment. Unfortunately, one patient died during the diagnostic procedure. Now, are there preferred technologies? And currently, there is no preference if this is performed in the clinical genomics area. There are advantages and disadvantages for each of these technologies. Targeted panel sequencing with a high coverage and very cost-effective exome sequencing has a lot of advantages. Genome sequencing has an even coverage, very flexible to use, but expensive. The costs vary, and you will have heard that the costs obviously drop. Exome sequencing can be done with under 500 pounds or dollar. Similarly, genome sequencing under $1,000. In practice, these costs are much higher because of the analytic pipeline required. We have, as part of this clinical genomics position statement, evaluated the gene defects that should be investigated, and as part of a consensus process summarizing multiple reviews of research groups, we came up with a group of 75 monogenic conditions that should be screened. We have to be aware that not all of these disorders will appear in the 75 disease group, and it can take years to evaluate gene defects. In particular, functional tests are required that are not standard of care, and in particular, if novel genes are identified. And this is an exemplar that we recently published as a part of a research group where multiple international collaborators contributed, and where a gain of function in SIK was identified. The follow-up after the identification of the first patients took several years. Now, I like to summarize. We have now a clinical genomics position statement that highlights the importance of multidisciplinary team approach, where next generation DNA sequencing is highlighted as standard of care, in particular in infantile onset inflammatory bowel disease and in very early onset inflammatory bowel disease, if there are relevant comorbidities or extraintestinal manifestations. Beyond this age group, it's very important if there are extreme phenotypes, and we do not recommend the routine screening of all IBD patients based on the costs and the low diagnostic yield. This should be performed if there are relevant investigations that are, for instance, hematopoietic stem cell transplantation. We recommend panel sequencing. We recommend functional assessment. And patients in their family with suspected monogenic IBD should be offered the opportunity to participate in research studies. What is very important, and we are a World Congress of Pediatric Gastroenterology, is that local knowledge should be implemented, regional environmental factors. The multidisciplinary team approach is applicable wherever in the world, but it might be centralized, in particular in low-resource countries. International clinics can help, and cost-effective technologies such as sequencing by Sanger approaches might be utilized. With this, I'd like to thank all my collaborators who contributed to this research.
Thank you very much, and thank you for that excellent talk. Can I just ask you the first question? So, in a 15-year-old, because that's the commonest age of presentation, with a strong family history, can you just tell us what would make you look for a genetic cause?
So if there is a 15-year-old that has a very severe, for instance, fistulizing disease, if there are wound healing problems from the beginning, if there is a failure, for instance, of anti-TNF treatment, or other family members sort of have already sort of a suspicious course, then I feel it's now justified to progress. There are diseases, for instance, like chronic granulomatous disease or XIAP deficiencies that are more common in these regions, and they should be excluded. We have seen patients who really sort of had exactly this setting and who had subsequent suffering for even decades. And I feel even in a 15-year-old in a very severe setting, one should consider genomics. In the classical 15-year-old that is well treated, that has not an extreme phenotype, the likelihood to find a monogenic disorder is exceedingly low.
Thank you. Now, I've got a great question in the chat. This is from Lissy Derrida, who compliments you on your great overview and asks the important question, is there any role for genetic counselling? And I presume she means in the severe phenotype early onset patients, but what would be your approach to that?
So, yeah, this actually is sort of is one of the questions why we have thought that we need to transition from the research setting that we have done for years into clinical practice, because in the research setting what we often do is we tell patients we want to do research, very low likelihood that there will be an outcome, and we sort of are not expecting that we feed anything back because it's very unlikely that this is of relevance to you. Now, with increasing knowledge, what is clear is that some parents are worried, they read things up, they want to know whether there is a condition, and they want to know whether there is no condition. And what we have felt sort of short in the research setting often is that we do not feed back negative findings, because that's very difficult. And similarly, one of the questions is, if there is a family with a child of IBD, what is the likelihood of having sort of, for instance, another offspring and another child? And these are settings that are best discussed in the clinical genomics setting, where a geneticist jointly with gastroenterologists can give exactly this type of counseling.
Thank you. I'm afraid we're going to have to move on, but there's quite a lot of questions in the chat, which I hope you'll have time to answer. But thank you so much for your excellent talk. We're moving on to the next presentation, and we're going to learn more and more by collaboration, data collection, and meticulous analysis. So it's my pleasure to introduce Teresa Drakowska, who is from the Czech Republic, to talk on the prediction of time to relapse in pediatric Crohn's disease patients on azathioprine treatment. And that's reporting a multi-center study of the pediatric IBD Porter group of ESPGHAN.
Hello, my name is Teresa, and I would like to thank you for having the opportunity to present our results of the study focused on prediction of time to relapse in pediatric patients with Crohn's disease on thiopurine treatment. The first picture illustrates the clinical issue which was at the origin of this project. In every newly diagnosed pediatric patients with Crohn's disease, a choice of appropriate long-term treatment is required. High effectiveness of top-down approach by initiating the treatment with anti-TNF agent has been recently proven in a randomized controlled trial held in the Netherlands. Nevertheless, this top-down approach has its limitations, such as high cost and limited duration of action of anti-TNF. Another options are thiopurines, which are effective and in comparison with anti-TNF cheaper, and while possible also being safer than in combination therapy. At last, there is a hypothetical option to leave the patient without a long-term treatment. So, reflecting this situation, our question is how to identify the patients who are the best candidates for immunomodulation therapy. The principal challenge lies in the fact that the decision has to be made at the time of diagnosis. Till now, we did not have any sufficient data to make an informed, evidence-based decision. We were aware that in order to realize this kind of project, it is crucial to obtain a large enough data set. Therefore, we decided to join with other centers specialized in pediatric inflammatory bowel diseases, and finally 13 European centers cooperated in this project. As a main data source, we used an international incidence register, EuroCase, and minority of the data that was not available in EuroCase was collected in a retrospect separately in each center. So, we started with a set of 2,241 pediatric inflammatory bowel disease patients. In the first step, 1,051 patients diagnosed with ulcerative colitis were excluded. Within the set of 1,190 pediatric Crohn's disease patients, 302 patients did not fulfill inclusion criteria and were dropped out. Further, we excluded 447 patients who met the exclusion criteria, and the final data set, which we used to search for potential predictors, consisted of 441 pediatric patients who responded to injection treatment, including exclusive enteral nutrition and corticosteroids, and who were in remission while on treatment with thioporins at week 12 after diagnosis. Finally, 61 patients with missing data relevant to the predictive model had to be excluded, and the data from 380 patients was used to select the best final model. Since the main aims of the project were identification of predictors and the creation of predictive model based on these predictors, time to first clinical relapse was set at the main endpoint. We defined the clinical relapse as a need for reinduction of remission or development of Crohn's disease-related complications counting abscess, fistula, and clinically significant stricture. As a first result, you can see the survival curve showing the time to first clinical relapse. So according to our data, half of the patients did not experience clinical relapse within 2 years of thioporin treatment initiation. Moreover, we can see that approximately 1/4 of patients were in clinical remission after 5 years of thioporin treatment. Due to small sample size, it is difficult to evaluate data after 5 years, but still we can notice that there are some patients in clinical remission even after 10 years of this treatment. So, the potential predictive factors were chosen from 6 different areas. We screened patients' demographic characteristics, laboratory parameters reflecting inflammation activity, growth data, endoscopic findings, findings of radiological imaging methods, and possibilities of treatment monitoring. Within the set of these variables, we selected a subset out of which the best final model was created. The definitive model consisted of 8 predictors. Although not a clinical applicable information, center of patient's origin was strongly associated with time to relapse, and thus it had to remain a part of the model. The other predictors were ileocolonic disease localization, level of C-reactive protein, body mass index Z-score, abnormal finding on imaging examination of sigmoid, and endoscopic changes consistent with Crohn's disease in esophageal tube, all of them obtained at the time of diagnosis. Here on a separate figure, you can see the last part of the model, the interaction of thioporin's dose and patient's age. In age group of 8 to 11 years, we observed significant protective effect of lower thioporin dose. However, based on available data, we are not able to explain this finding. In other age groups, thioporin's dose had no significant effect on time to relapse. So combining the risks, we separated patients with the worst and the best prognosis. Based on the coefficients of the final model, the high and low risk groups are defined by parameters you can see in the screen in front of you. In general, the low risk group was associated with interaction of a specific age group and thioporin dose, higher body mass index Z-score, and normal findings on esophageal endoscopy and sigmoid imaging. Finally, we developed a web-based application to easily transfer this new knowledge into clinical practice. Using this web-based tool, the individual values of predictive model are filled in, and then the individual estimation of time to relapse on thioporins may be visualized, differing on the basis of input values. So in conclusion, we identified 6 independent predictors available in diagnosis of early thioporin treatment failure in patients who achieved remission on exclusive enteral nutrition or corticosteroids and were concomitantly treated with thioporins. We developed a model for individual prediction of time to relapse in pediatric patients with Crohn's disease using data from International Multicentric Register. In our sample, 51% of patients maintained clinical remission after 2 years of tiopronin treatment initiation. Therefore, we suggest that tioprins can still be considered a suitable treatment option for a subset of pediatric patients with Crohn's disease. And we developed web-based tool allowing easy identification of patients who are most likely to benefit from tioprins treatment. At last but not least, I would like to thank all my collaborators for all their work, time, and valuable suggestions. Thank you for your attention, and I will be more than happy to answer your questions.
I'd like to thank you for your excellent talk and meticulous presentation of the data. One of the interesting things that comes out of a data set like this is the question as to whether if 50% of patients on azathioprine are in remission at 2 years, does that suggest some of those patients didn't need azathioprine? And it goes right back to the early studies of azathioprine. So do you think that your data at least tells you risk factors for treating it with azathioprine, but also starts to inform us about the population that might not need the azathioprine, bearing in mind the anxieties about long-term toxicity?
Yeah, I'm sorry, I didn't hear the last part of the question.
I mean, that was just bearing in mind the issues of long-term toxicity. Is there, from your data set, anything that helps us decide who shouldn't have azathioprine?
Yeah, actually, based on our data, we think that there is a subgroup of patients who are supposed to use azathioprine, but we really need to be able to define this subgroup of patients. And actually, I'm not sure if we are sure that azathioprine is like more dangerous or is not safer than biologics. I think we are not able to compare it at the moment, so we don't know, and maybe we will see in the future.
It'd be great to see the next bit of information from this data set. The question from the audience is, did you evaluate the effect of TPMT activity in relapsing patients? So are there any patients in your cohort who are, for example, TPMT deficient?
Yeah, actually, we were not able to do this analysis because there was so lack of data. Actually, so many centers tested. There was almost no center who tested TPMT metabolism, so we are not able to evaluate it because we didn't have this data.
Okay, look, thank you for your excellent presentation, and now I'll hand back to my co-chair, Eric Benchimol.
Thank you. That was a truly great study. The next presenter really needs no introduction. Most of us know Dr. Escher from Rotterdam in the Netherlands, who will present on treatment endpoints in pediatric and adolescent IBD.
Ladies and gentlemen, Mr. Chairman, my name is Hankje Escher. I'm a pediatric gastroenterologist from Rotterdam, the Netherlands, and we are going to talk about treatment endpoints in pediatric inflammatory bowel diseases. So when we talk about endpoints, it really depends on which point of view we are taking. Is it the doctor's point of view, so our point of view? Then we think about clinical disease activity, endoscopic measures, histology, MRI, fecal calprotectin. We look at growth, we worry about bone health and complications long term. If we take the point of view of the patient, then obviously you see a girl here that may have abdominal pain. She worries about her disability. She cannot go to school or go out with friends. Her mood may be low. She can be socially isolated. That is very worrying. And something that is in her mind is surgery, which she definitely doesn't want. And the point of view of the parents is a little bit different also. They think about whether their child can go to school and the impact of the disease on the family, on the rest of the family, and the parents worry more than children about long-term outcome of disease. And then finally, the endpoint of the pharmaceutical company is completely different from point of views from doctors, patients, and parents. Pharma worry about pediatric investigation plans, market authorization for their new drugs. They are worrying about the label, and they think a lot about money, of course. So when we assess clinical disease activity in pediatric IBD, it's quite easy. You have multiple apps that you can download on your iPhone that can help you calculate clinical scores for pediatric Crohn's disease or pediatric ulcerative colitis, the PCDI and the PUCI. That's what we all know. But if we want to score the disease severity, so not disease activity, which is a moment in time, but disease severity, we're talking about disease behavior in time, course of disease over time, therapeutic response, and long-term complications of the disease. And this is a little bit more complicated. So first, looking at clinical treatment endpoints in pediatric Crohn's disease, we all know the Pediatric Crohn's Disease Activity Index, which was developed already 30 years ago now, that comprises history, laboratory markers, and physical examination. And there are also several versions that skip the laboratory markers and skip the height marker, the abbreviated PCDI or the shortened or the weighted PCDI that are a little bit easier to use. Anyway, clinical response is defined as a reduction in PCDI of 12.5 points or more, and clinical remission by PCDI score of less than 10. Easy. So when we assess endoscopic disease activity, it's a little bit less easy. So for this we can use the SES-CD, the simple endoscopic score. It's not so simple because for each segment of the colonoscopy tract, the rectum, sigmoid, left colon, transverse colon, right colon, and ileum, we have to score the presence and the size of ulcers, the ratio of ulcerated surface, of affected surface, and the presence of narrowing. And everything added up together can yield us a score. And for endoscopic response, this is defined as a SES-CD of more than 50% reduction. And endoscopic remission, or what we call mucosal healing, is a score less than 3. The problem is that endoscopy does not always reflect the clinical status of our patients. So, for instance, we can have this young girl lying in bed and looking very miserable, but her colon can be absolutely normal. But also the other way around, the happy girl on the lower panel, no complaints, no abdominal pain, but when you do the colonoscopy because of, for instance, some weight loss, you see a severely inflamed terminal ileum. So there is not a good correlation between the two. And this is shown in this study by Dan Turner, but also in several other studies, that the correlation between the PCDAI, the clinical index, and the SES-CD, the endoscopic index, is only fair. There's a newer index, the mini index, the mucosal inflammation non-invasive index for pediatric Crohn's disease, that consists of a stool marker, fecal calprotectin levels, and ESR and CRP levels, adding up to a score that correlates better with the endoscopic score than the PCDAI. So for this mini index, the cutoff value of 6, so everything below 6, correlates well with mucosal healing with a positive predictive value of 86%. So one example from a clinical trial in pediatric Crohn's disease is, of course, what you all know, the TISKIT study, a very important study where patients with new onset Crohn's disease, pediatric patients were randomized to receive first-line infliximab or conventional treatment with exclusive enteral nutrition or prednisolone. And you can see here the results of the first 10 weeks. Clinical remission in 59% of the infliximab, and 34 patients only reached remission when treated with EEN or prednisolone. But more importantly, what I want to show you here is the difference between the mucosal healing, which is in the figure, which was achieved in 17% only of the patients on conventional treatment, and 59% in the patients with first-line infliximab. So there's this big discrepancy between clinical remission, and only half of those patients had mucosal healing. So when we talk about remission in pediatric Crohn's disease, clinical remission is defined by PCDI less than 10, endoscopic remission or mucosal healing by SES-CD less than 3, and then there's a new definition which we call deep healing, and this is a combination of mucosal healing and transmural healing seen by MR enterography. And if the radiologist scores this as a global assessment on a visual analog score of 0 to 100, a score less than 19.5, then this can be defined as transmural healing. So mucosal healing plus transmural healing, that's deep healing. And now it's interesting to compare this to fecal calprotectin levels. If the fecal calprotectin level is less than 300, this predicts mucosal healing. And if the fecal calprotectin level is less than 100, this predicts deep healing. So let's now switch to ulcerative colitis. Well, we all know the PUCAI, the Pediatric Ulcerative Colitis Activity Index, that was developed by Dan Turner. And it's a wonderful score that we can use on a daily basis. And clinical response is defined as a PUCAI change of 20 or more, clinical remission by PUCAI less than 10. And then going to endoscopy in pediatric UC, but also adult UC, actually is an adult score, the Mayo score that we like to use, that varies from 0, where there is no disease in the colon, to 3, where you see severe ulcerations and spontaneous bleeding. And of course, the mucosal healing is defined as an endoscopy score, Mayo score of 0. And when we look at correlation between clinical index, PUCAI, and endoscopy, this is a little bit better in UC than in CD. Actually, one study states that there's a strong correlation between the two, but 20% of the patients who had a PUCAI less than 10 still had mucosal inflammation. So the correlation is not perfect. And especially in patients with PSC IBD, the correlation is less good. So it's possible that a PSC IBD patient is feeling well but has severe endoscopic disease. So if we focus on the treatment goals for our young patient, her well-being is obviously a goal. But for us as doctors, we want absence of ulceration. We want this beautiful mucosal healing. So for the past 5 years, the treatment strategies have really evolved. The treatment goals have evolved. So first we were aiming for symptoms, clinical remission, and even steroid remission, steroid-free remission, I should say. But what we now want is mucosal healing and even deep remission in order to change the course of disease. So what about the patient? Well, the patient is the one who suffers from the burden of disease. And a very nice tool is the IBD disc that's developed to give patients a self-administered tool to assess disability in IBD. And there are 10 issues that have to be scored by the patient, him or herself. ranging between 0 and 10, such as abdominal pain, regulating defecation, interpersonal relationships, education and work, sleep, energy, emotions, body image, sexual functions, and joint pain. And if you look at this example, this on the left, this is a patient that is initially assessed with active IBD, and the scores are high and the disease burden is high. And what we aim for during treatment is to get this spider web smaller and smaller. So the therapeutic goal is to get lower scores and low burden. In children, there are several studies on self-report or patient-reported outcome in IBD. And all these studies are promising and important because having patients report themselves about their symptoms, this really encourages self-management. And all of the studies show that clinicians really underestimate the disease burden of the patients. So, ladies and gentlemen, I have some conclusions for you. First of all, I've told you that there is a difference between disease activity and disease severity. To assess disease activity by clinical scores, endoscopic scores, or fecal calprotectin, that's easy. But to assess disease severity is much more complicated. Clinical scores do not correlate well with mucosal disease in Crohn's disease. In ulcerative colitis, it's a bit better, but not 100%. And in IBD PSC, it's worse. There's not such good correlation. Treatment endpoints, it really all depends on the point of view. Is it the doctor's point of view? Then we aim for mucosal healing or deep healing because we know this results in a better course of disease. But if you ask the patients, they want less burden of disease. So, ladies and gentlemen, thank you very much. This is the end. And I'm ready for your questions.
Thank you very much, Henkie. I believe you are online if you want to unmute and show your video. There you are. Nice to see you.
Hi.
So we have some questions in the audience. One in particular is asking you to comment on the STRIDE-2 therapeutic targets led by Dr. Turner. And be careful, Dr. Turner is in the audience. But I think Dr. Lass wanted you to comment on endoscopic remission being a target, but not histologic or transmural remission yet. Do we lower our expectations?
So you mean, do we target at histological or just endoscopic remission?
Yeah, so I think the reference was in comment, the comment was in reference to the STRIDE-2, which said the target remains endoscopic healing and not histologic remission yet.
Yes, and you're asking me if I agree with that, or how do you do that?
I think that's what the audience member is asking.
Yes, well, I mean, we are all clinicians, and if you want to aim at histological remission, I mean, you have to, I mean, it's practically undoable, I think, because there will almost always remain some inflammation in the mucosa if you look through the microscope. So, I mean, you want the histology to be as normal as possible, but I think it's utopia to aim for complete histological remission.
Yeah, I think I tend to agree that, what happens if you don't achieve that, right? What do you do? Do you move on? Do you burn through therapies? So I think there's a lot of unanswered questions which are reflected in the STRIDE recommendations. I think, Mark, did you have a question?
Yeah, I did have a question which I was struggling to type in, but thank you for this excellent talk. If the fecal calprotectin is less than 100 and the inflammatory markers are normal, you can still have stricturing disease. Now, I accept in the individual patient that would be down to clinical assessment. But how do you think we factor that into the research outcomes?
That's a good question. Well, I think if there's stricture in disease, this will be seen in the clinical disease activity index, because these patients will probably have abdominal pain. So, I mean, it will surely come out of doing clinical disease activity. So, is that what you mean?
You know, it's just really, it's a comment as well. It's just we could be making an assumption in a population, if the calprotectin and the inflammatory bowel disease is normal, that the disease is truly in remission, whereas we would still have to use indices and other parameters to exclude stricturing disease.
Well, that's why, I mean, none of the research endpoints will use only calprotectin. It will always be combined with a clinical disease activity index, and more we're going to use the MRI to assess not the mucosa, but what's beneath the mucosa. So, I mean, when you combine all these, you will always know the exact disease activity wherever it is.
Thank you.
So we have one more question in the Q&A box. Dr. G. Suk Park asked, what's the proportion of pediatric IBD patients who actually achieve the treatment targets?
Well, my guess would be, if you define the treatment target mucosal healing, which we did, it will probably be, it will always depend on what treatment is used. But my guess is, and I'm now also basing this on the TISKIT study that I mentioned, it will be like about 50 to 60% in patients who are treated with anti-TNF. Well, all the other less effective treatments, such as steroids or exclusive enteral nutrition, it's probably not more than 20 to 30% who have.
Yeah. And I imagine if your target is histologic remission, it's quite a bit lower than that for both.
Yeah, it's going to be much lower. It's like 5% or 10. Yeah, 5%. I think 5 to 10.
Yeah. Okay, thank you very much. I think we will go on to the next speaker. Thank you. That was an excellent talk. The next speaker is Dr. Gemma Pujol from Spain, who will speak to us about the STEP-CD study, ustekinumab use in pediatric Crohn's disease, a multi-center retrospective study from the Pediatric IBD Portal Group of ESPGHAN.
Good afternoon, everybody, and thank you for the opportunity to present this study today on behalf of the IBD Interest and Portal Group of ESPGHAN. These are my conflict of interest. As you well know, ustekinumab is a human monoclonal antibody that binds to the p14 subunit that's common to interleukin 12 and interleukin 23. Both cytokines modulate lymphocyte function, including T helper 1 and T helper 17, that may lead to gut inflammation. The phase 3 studies performed in adults, the Unity 1 and Unity 2, showed that ustekinumab was effective in those patients with moderate to severe Crohn's disease, with a response of 34% at week 6 on those patients that were anti-TNF exposed, and more than 50% on those patients that were naive to anti-TNF. The maintenance trials demonstrate that ustekinumab was also effective in the maintenance of remission, with a remission rate over 50% at week 44. Currently, the use of ustekinumab in pediatric population is increasing, but pediatric data is scarce. Only case reports and some observational cohort studies are published until now, and clinical remission rate from 40 to 50% is reported at 1 year. The aim of our study is to describe the effectiveness and safety of ustekinumab in pediatric Crohn's disease patients in an European multi-center core in a real-life practice. And the primary outcome is exclusive enteral nutrition and steroid-free remission at week 6. And the secondary outcome was exclusive enteral nutrition and steroid-free remission and safety at 12 and 52 weeks. For that purpose, we performed a multi-center retrospective observational study with 23 participating centers from Europe and Israel. And the inclusion criteria were children from 2 to 18 years old with Crohn's disease established, or the diagnosis established by Porto criteria, that has been treated with ustekinumab, at least one dose, and that the ethical committee approved the study in their centers. We record medical data. As you can see here, we include these variables in the study, and these are our results. We include 101 patients, 50% of them were male, and the median age at diagnosis was 9.7 years. The median age at ustekinumab initiation was around 15 years, and the median duration of the disease was 4.3 years. Regarding CD location, as you can see here, most of the patients had an ileocolonic involvement, and a quarter of our patients also present perianal disease. At baseline, the disease behavior was inflammatory in most of the patients. And regarding disease activity, the median weight PCDI at baseline was 38.7, with moderate or mild disease activity in most of the patients assessed by physician global assessment. Regarding test results, blood test results, you can see here that the CRP was, the ratio CRP was 1.6 upper the normal limit, with a median fecal calprotectin around 1,000. Only 36 patients had a baseline endoscopy with a median CSCD score of 17. Regarding prior treatments, we would like to remark that 99% of our core were being exposed to anti-TNF agents, and more than 60% received 2 or more different anti-TNF. The 22% of the patients also has been exposed to vedolizumab, and at baseline, around 50% of the patients were on concomitant immunomodulator. Regarding ustekinumab dosing, as you can see here, the most frequent induction strategy was ustekinumab intravenous induction. Those patients over 40 kilograms received the adult dose adjusted by weight, and these patients under 40 kilograms received a median dose of around 6 milligrams per kilogram. 10% of the patients received subcutaneous induction that was performed before the intravenous ustekinumab formulation approval in their countries. The most frequent maintenance strategy was ustekinumab 19 milligrams subcutaneously every 8 weeks. During the follow-up, 26 patients required treatment intensification, regaining response in around 70% of them. We define the clinical remission as the weight PCDI under 12.5 with exclusive enteral and steroid-free remission, and the complete deep remission was defined as clinical remission plus normal CRP and fecal calprotectin under 100. The primary outcome was achieved by 39% of the patients at week 6, and at week 12 and week 52, the clinical remission rate was 38.5 and 51% respectively. The CRP ratio over time decreased with the statistically significant differences between baseline and week 6 and baseline and week 52. The fecal calprotectin also decreased over time, but not significant differences were reached. In the multivariate analysis, we saw that remission at week 6, ustekinumab intravenous induction and older age at ustekinumab initiation were associated with ustekinumab response at week 12. And regarding safety profile, we report 7 adverse events. All of them were mild or moderate, and only 1 patient with lingual vasculitis has to withdraw the drug. We know that our study has some limitations, mainly for retrospective design study and for the heterogeneity of patients, different activity, different location of the disease, and also for the lack of a standardized ustekinumab treatment. Moreover, the clinical remission, it was based in clinical parameters, and no endoscopic and neither histological data during follow-up was recorded. So, however, this, to our knowledge, this is the largest cohort of ustekinumab used in pediatric Crohn's disease patients, and despite its limitations, our results suggest that ustekinumab may be effective and safe in a subcohort of refractory pediatric Crohn's disease patients at short and mid-term follow-up. Our results are similar to the real-world experience published in adult patients with Crohn's disease, but larger cohorts as well as prospective study and controlled clinical trials are needed to confirm the results. Finally, I would like to thank all the participants to make this study possible. Thank you very much for your attention.
Thank you very much, Dr. Pujol. Lots of information, and there's quite a few questions, so we'll try to get through them quickly. I had a very first question, if you don't mind. Your primary outcome was week 6, 39.2%. It looks like week 12, about 38.5% remission, and then week 52, it jumps to 52% remission. So it sounds like this may take a little while longer than we're used to, at least with intravenous anti-TNF, to get a good remission, a solid remission. Do you feel that way, and how long should we be waiting before giving up on ustekinumab?
I don't know if I have understand the question very good. I think that you are asking me if the durability of the drug is over the other biologics, or
no. So what I meant was that in your study, at week 6 and 12, you had around 38 or 39% response remission as defined by your endpoints, and at week 52, it sounded like it jumped to about 52%. Corticosteroid-free remission. So that implies that it takes longer than 12 weeks to get, your endpoint. So how long do you usually wait? How long would you recommend waiting before abandoning therapy in ustekinumab?
Well, here there is a tricky question that this is clinical remission, but if we consider sustained clinical remission without the flare that need other medication or surgery, this sustained remission fall to 30% of the patients. So maybe this is the tricky part of the study. So it seems that the remission rate is really very stable during the different points that we have observed.
Okay. And then some other questions from Dr. De Ritter and Dr. Gasparetto related, I think, to a certain extent. Do you advise the use of TDM, proactive or reactive, with ustekinumab? And what about mono versus combo therapy? Do you find that was a significant factor?
Regarding the TDM with ustekinumab, we didn't analyze in this cohort because it's an observational retrospective study and it was not available. And so it seems that maybe the TDM is not, we have no data today for this question, enough data today. And regarding the monotherapy versus combo therapy, we saw in the study that the remission rate, it was not no differences between these patients in monotherapy or those patients in combo therapy, neither at week 6, but neither at week 52.
Thank you.
It's not a fact.
Thank you. And one final question from Dr. De Ritter. For the very young patients, after induction of 6 milligrams per kilogram, did you tend to lower the dose to 45 milligrams subcutaneous for maintenance, or do you use 90 milligrams for all? And I say you in the general, obviously, this is an observational European study. So the majority, what did they do in that study?
this study, most of the patients, well, the median age of the patients was 15 years at baseline. So is a cohort with older patients, and the smallest patient was 18 kilograms, and this patient received as maintenance dose 19 milligrams every 8 weeks subcutaneously. No patients with 45 milligrams.
Perfect. Thank you. Thank you very much for an excellent presentation and an excellent study. I'll hand it over to Dr. Beatty for the final presentation.
Yeah, thanks very much, and great talks so far. I'm really looking forward to the next one, which is big news in 2020. So some big news that wasn't COVID-19. So big news in 2020, the new CD guidelines, and that's Patrick van Reenen, and welcome, and we'll look forward to your talk.
My name is Patrick van Reenen, and I'm a pediatric gastroenterologist at the University Medical Center in Groningen, the Netherlands. The ECHO-ESPAN guideline update for the medical management of Crohn's disease was published in the Journal of Crohn's and Colitis and is open access. In the end of this presentation, I will provide a QR code. If you scan that code, you will be channeled to the website of JCC for a free download of the guideline. In this presentation, I will highlight the most important changes compared to the 2014 guideline. The first guideline, with lead author Frank Rummel, has been cited by 206 PubMed registered articles. The following clinical questions will be answered in the guideline update. 1. What is the treatment target, and what surrogate measures can be used? 2. How to choose the first induction therapy? 3. What are the options for maintenance therapy? 4. What to do when your first choice induction therapy fails? 5. How to get the most out of an anti-TNF treatment? And 6. What to do when anti-TNF therapy fails? Let's start with the treatment target in the new guideline. We have moved away from the old treatment goal, clinical remission. Mucosal healing, rather than clinical remission, is associated with favorable long-term outcomes. Although histological remission is considered an even deeper remission, it is currently still controversial as a treatment target in Crohn's disease. This table shows that endoscopy is the gold standard to diagnose mucosal healing. It has good test validity, is responsive to changes in the severity of inflammation, has a good signal-to-noise ratio, but repeat endoscopies to evaluate resolution of inflammation are impractical. There is an increasing demand to replace invasive procedures with surrogate non-invasive markers to evaluate mucosal healing. Fecal calprotectin has good validity and responsiveness and is a practical test. It scores better as an isolated surrogate test for mucosal healing than CRP and the weighted PCDI. CRP and clinical activity indices, such as the PCDI, have poor validity when used in isolation. However, a composite score of fecal calprotectin, CRP, and PCDI is currently considered to be the best suitable non-invasive test to evaluate the response to treatment. The choice of the initial induction therapy is critical. In patients with a pure luminal Crohn's disease without additional risk factors, first-line induction therapy is either exclusive enteral nutrition or corticosteroids. In patients with predictors of poor outcome, including growth delay, extensive disease, perianal disease, or stricturing disease, upfront anti-TNF is advised. The idea behind this advice is that chronicity of inflammation and progressive bowel damage may be reduced when the disease is optimally responding to anti-TNF therapy in the early years of the disease course. What are the options for maintenance therapy? Methotrexate and thiopurines are equally effective in maintaining clinical remission, but there are concerns around the long-term safety of thiopurines. The absolute risk of malignancy in IBD patients treated with thiopurines is small, but cannot be neglected. The main risk is for developing lymphomas and non-melanoma skin cancers. The benefits of long-term immunosuppressive regimens should therefore be considered on an individual patient basis. To date, no such risk has been detected with low-dose once-weekly methotrexate as concomitant immunomodulator. In children with low-risk Crohn's disease who achieved clinical remission, monotherapy with maintenance enteral nutrition, that is at least 50% of the daily energy requirements, can also prolong remission. What to do when your first choice induction therapy fails? If remission is not reached in the first 12 weeks, the expert panel suggests not to waste time with another first-line induction and advises to step up to anti-TNF therapy. If the treatment target is reached within 12 weeks, but the disease flares while on maintenance therapy, then reinduction with first-line therapy can be attempted before stepping up to anti-TNF therapy. The central theme here is no lingering. In other words, do not delay a step up to anti-TNF treatment longer than necessary. Tricks to get the most out of an anti-TNF treatment are shown on this slide. Remission is maintained longer when infliximab is combined with an immunomodulator. The available evidence overall suggests that adalimumab monotherapy is appropriate when started as a first anti-TNF agent. Furthermore, TDM-guided monitoring, that is measuring drug levels, is considered more effective to get the most out of an anti-TNF treatment than empirical dose escalation. If you start with measuring drug levels in the induction phase, followed by dose optimization, you may reach therapeutic levels earlier. This is especially of importance for children with perianal disease or those with an expected accelerated clearance of the drug, such as children below 30 kilograms, those with extensive disease, and those with low serum albumin. TDM is usually done at the end of induction, that is, before the fourth infliximab infusion, when the target trough level should be over 5 micrograms per milliliter. In patients at risk for accelerated infliximab clearance, an infliximab concentration over 25 and over 15 micrograms per milliliter at infusion 2 and 3 respectively are associated with better outcomes. Early proactive TDM in adalimumab users is done at week 4, that is, before the third adalimumab injection. What to do when anti-TNF therapy fails? First, you have to find out why it failed. For that purpose, trough levels should be measured. In case the trough level is in range, you probably deal with a pharmacodynamic loss of response, which means that the current anti-TNF agent is not effective. In that case, there is no other solution but to switch to an out-of-class biological. In case the trough level is too low, either one of the following situations apply. You may deal with pharmacokinetic failure, which can be solved by simply escalating the dosage. When anti-drug antibodies are present, you deal with an immunogenic failure. With low titers, the remedy is to escalate the dosage and to add an immunomodulator, if not yet done. With high anti-infliximab antibody titers, you may consider switching to adalimumab. This slide shows therapeutic options after anti-TNF failure. In fact, only one option is supported by the expert panel. Ustekinumab, a monoclonal antibody targeting interleukin 12 and 23, has demonstrated efficacy for induction and maintenance of clinical remission in randomized controlled trials in adult patients with active Crohn's disease, including those who had previously failed anti-TNF therapy. Data on ustekinumab efficacy in pediatric Crohn's disease are still limited. Target trough levels of ustekinumab are not yet well established. Vedolizumab is a gut-selective humanized monoclonal antibody targeting the alpha-4 beta-7 integrin that is effective in patients with IBD who are refractory or intolerant to systemic steroids, immunomodulators, or anti-TNF agents. Vedolizumab is effective in both Crohn's disease and ulcerative colitis. Anti-drug antibody development is uncommon. Severe adverse events leading to discontinuation of treatment with vedolizumab are rare. Vedolizumab use is not associated with increased risk of opportunistic infections or malignancy. The available literature does not show any benefit of the use of probiotics or fecal microbiota transplantation in patients with Crohn's disease. In conclusion, new themes in this guideline update include 1. The presence of predictors of poor outcome, the so-called POPOs. When not present, then you can try to induce remission with exclusive enteral nutrition or steroids. When POPOs are present, upfront use of anti-TNF therapy is advised. 2. When the treatment targets low values on the composite score of fecal calprotectin, C-reactive protein, and PC-DIE is not reached within 12 weeks of first-line therapy, do not waste more time, but consider an early step up to anti-TNF. And 3, close monitoring is necessary to evaluate the response to treatment. This includes serial fecal calprotectin measurements and early proactive TDM. This guideline update was delivered by an outstanding and dedicated team of 25 experts representing major European, Canadian, and Israeli centers in pediatric IBD care. We formed 10 working groups, reviewed the literature until the 1st of March 2020, and generated provisional guideline statements. The 30 provisional statements and the supporting evidence tables were shortlisted based on the clinical importance for the medical treatment of Crohn's disease. Some statements were further refined during pre-corona face-to-face meetings and then subjected to a vote. The statement was considered as final when at least 80% agreement was reached during voting. 8 provisional statements were ultimately rejected, and the remaining 22 statements contained in this guideline. Each statement is framed and followed by a discussion of the evidence. Practical guidance sections complement the evidence by providing additional information not covered by the statements. Once again, I thank all who contributed. Thank you for your attention. You can scan the QR code for a free download of the published guideline. Please inform the Congress participants about this presentation using Twitter and this hashtag. In case you want to contact me by mail, here's the address. Enjoy the rest of the Congress.
Thank you so much for that excellent summary of the new guidance, and congratulations on the QR code, and I hope very much that everyone takes advantage of it and uses it. So can I ask you the first question? So there's consensus that azathioprine plus anti-TNF works better than TNF on its own. That seems to be how I would interpret the vote. So
especially for infliximab, yes.
Yeah. So if you start infliximab, should you start azathioprine at the same time? I realize that's not a straightforward question. Should you start it 2 weeks later? But is that what the guidance is saying, is that if we use infliximab, we should be using athioprine as well?
Yeah, that is correct. If you start it at the same time, then at least you prevent the creation of antibodies against infliximab. And for how long do you have to continue with this combo therapy? Nobody knows exactly, but there are indications that if you combine thiopurins and infliximab for 6 to 9 months, and then you stop, then the highest risk for antibody formation has gone. So after 6 to 9 months, some say 12 months, you can stop with the combo therapy and you continue with monotherapy. But for patients who have a complex disease with a high risk of a complicated disease course, then it might be useful to continue combining the two.
Thank you. I think that's very clear, actually, and very helpful. Rafiq Mohammed from Birmingham has asked a question which you might not want to answer, but it's, what about the rejected statements? Do you want to share any of the rejected statements?
Well, then I have to dig deep into my laptop before I can tell them. So I don't think that is of any use for this Q&A session, I think.
Yeah, no, that's fine. I'm happy with that. So 2 questions about specific monoclonals, and I think they're interesting questions for us to think about. So would you think that, do you have any specific anti-TNF agent for fistulizing Crohn's disease? Or would you use either infliximab or adalimumab, dependent on circumstances, availability, and patient preference?
Yeah, answer B is I think, the best answer we can give. There are no randomized controlled trials or head-to-head trials that compared infliximab with adalimumab, especially not in pediatric fistulizing Crohn's disease. What we know from adult studies is that both have an effect, and there is not a big difference between infliximab efficacy and adalimumab efficacy in perianal Crohn's.
Okay, thank you. And from Lorenzo Norsa, I think a great question, actually. If anti-TNF fails, do you go for ustekinumab or vedolizumab?
I think that is depending on the local situation. In the Netherlands, vedolizumab is still off-label, but it is easier to get compensated for prescribing vedolizumab. Ustekinumab is off-label, and it's either the health insurance that needs to pay for that large amount of money, or the hospital. So there are other reasons to prescribe either ustekinumab or vedolizumab. If you ask me personally, I think I have a small. I tend to prescribe ustekinumab a bit more in Crohn's disease than vedolizumab.
Mark, I have a question, if you don't mind me jumping in.
Yeah, absolutely.
We have a few minutes. So I had the experience, Patrick, of also creating guidelines before the COVID-19 pandemic, and then realized things changed after the COVID-19 pandemic. I wonder, can you speculate on what might be different in your recommendations in light of COVID-19? For example, would your choice of induction therapy change? Would you use more vedolizumab, less steroids, and so on?
Well, there's not much information on that, even in the adult IBD community. But one drug really stands out as a drug that you should not use in active COVID infections, and that is corticosteroids. So I think that if you deal with a patient who has an active COVID infection and you need to induce remission in that patient, I would advise not to prescribe corticosteroids. So either go for exclusive enteral nutrition or start with anti-TNF upfront.
And would that make you more likely to choose adalimumab than infliximab, the post-COVID situation? Because it has been quite a challenge to keep our patients protected from COVID environments. And of course, we don't know what's going to happen next with the pandemic.
If you aim at keeping the patient out of the hospital and promote treatment at home, then that would be in favor of adalimumab. Is that what you mean?
No, that I think it's an interesting dimension, and certainly our adult colleagues have pushed that quite hard.
Well, I've seen a trend in the past, I think, 1 to 2 years that more and more adalimumab is prescribed as the first-line anti-TNF drug, while before that time, infliximab was the first choice.
Mark, I have to say in Canada, we give infliximab in infusion clinics, so not necessarily in the hospital. And the infusion clinics actually were very, very safe. They worked very hard to ensure safety and that everybody was isolated and safe to get their infusions. We actually had a case who contracted COVID the day before going for an infliximab infusion in clinic, and nobody in that infusion clinic contracted COVID. This was early in the pandemic. So for us, it wasn't as big an issue, I think.
But even I think in Europe, in hospitals, the spread of COVID was not so high, at least not in pediatric clinics. So even infusions in the hospital were without any problems, I think, at the pediatric school. Yeah.
So it's my job now to bring this session to a close, and I'd like to finish by firstly thanking our technical host, Sabi, who seems to have behind the scenes made all of this work fabulously, the organizers of this conference for this fantastic virtual event, my co-chair, the speakers, but also the delegates. And one of the things in these virtual events, you don't know how many delegates are around, but I'll just share with the delegates, there's been more than 250 people actively participating in this symposium, and I would like to thank them as well for listening, and hope very much you enjoy the rest of the conference. Thank you.